Hello everyone and welcome to the third Oculus Refractive Camp. My name is Trisha de Jager and on behalf of Oculus, I would like to thank all of you for attending this session. We are delighted seeing so many of you joining today. Allow me also to welcome our esteemed panel of speakers, Professors Ambrósio and Belin, Drs. Vinciguerra, Roy and Flockerzi. It's an honor to have you today presenting for us. Thank you for the time that you took to prepare your talks, and we are all very eager to listen to you. Before I hand over to Professor Ambrósio, who will be doing the first talk, a few technical things. If you have any questions during the session, please write it in the Q&A section assigned to all panelists. The talk will be plus minus 75 minutes, but it is also recorded. So if you have, later on, you can join the Oculus YouTube channel to watch it. This is the list of talks that will be presented today, but Professor Ambrósio will introduce each of the speakers. And if you have any technical difficulties regarding your sound settings, at the bottom of your display, you will see there's 3 dots and you can activate that and change your sound settings. So without further ado, Professor Ambrósio is the first presenter. Professor will talk about the enhanced diagnostics of corneal ectasia. Professor Ambrósio, I'm making you the presenter. Change the role. There we go. And you can start sharing your slides. Thank you.
Thank you very much, Trisha. It was a very nice introduction for this great webinar. And I'm very happy to participate in this great meeting with some great speakers, friends all over the world. Here in Brazil, it's 8 o'clock sharp in the morning. And when we think about enhanced ectasia diagnostics, we do have to consider what we are trying to achieve with the diagnostic imaging that we have today. Of course, I have to mention that I have a long relation with Oculus and other companies for over 15 years, and also with my colleagues in the BRAIN group, the Brazilian Artificial Network, Intelligence Network, that we completed 10 years. And I start with a quote from Socrates: "We know that we have to improve." I would understand this, that we are always learning, and as much as we know that we need to know more. And understanding that is very important, because when you think about enhanced diagnostics for ectasia, we have to consider that we are going beyond, not over, the detection of keratoconus to understanding ectasia susceptibility. And this is different than when we look at the patients that are at high risk for ectasia, pre-op to LASIK or SMILE or PRK, or even cataract surgery. We have to understand what is screening, what is diagnosing, what is staging the disease. Clinical management is also going to be definitely impacted by this knowledge, and patient follow-up. So the hows, we have to understand what we're trying to achieve, what we have in terms of the diagnostic tools, and this is multimodal imaging. Multimodal imaging includes topography, tomography, biomechanical assessment, corneal detail with a segmental tomography, wavefront of the whole eye. All this data, along with axial length, will be integrated. And this is not only for laser vision correction, the cornea. Recently in the JCRS, I collaborated with Dr. Ko and her group in Japan, so that we understand pre-op cataract surgery, that we have to understand ectasia for many reasons, because of optical properties after surgery, and also if you consider a laser vision correction after surgery, it will be very important to have this type of screening pre-op LASIK, pre-op cataract surgery as well, not only like what we do for LASIK. So we have the Pentacam, which gives you a multimodal imaging with axial lens and ocular wavefront beyond corneal tomography and anterior segment tomography. We have displays with the indices to screen for different situations like angle closure glaucoma, ectasia, and the nice Belin ABCD, the progression display. So, but we think about ectasia, we have to consider the biomechanical role. This is a very nice model that was started by Cynthia Roberts and BJ Dubes, in which we start with the modules of elasticity. The focal reduction on the modules with elasticity will lead to changes in the tissue, and this focal thinning will be related to the increased strain, and then you have a cycle that will lead to the change that we see in the clinic with the changes in the cornea that you can get at the slit lamp, loss of distance correct vision because of irregular astigmatism. So biomechanical decompensation of the cornea is related to two factors, the cornea resistance and the impact from the environment. Impact from the environment, of course, we have laser vision correction procedures that would affect the cornea in different ways, like PRK leads to less impact than LASIK, and SMILE is kind of in between. But eye rubbing is the most important impact from the environment, and any cornea may develop ectasia. So if you want to avoid ectasia, start by telling patients not to rub the eye. Eye rubbing is bad for you, so it's a general message, but this message can impact any cornea surgeon or professor. Eye rubbing aggravates keratoconus and may even cause ectasia. Those are different things. So that's the soul of our campaign, the Violet Tune, which I invite all of you to collaborate, just post about keratoconus, about awareness, so that patients can live better with the disease. Risk factors for ectasia has been long studied. A nice contribution by Brad Random and his group in the mid-2000s is related to topography, and also he included other factors like residual stromal bed, thickness, and level of correction. But age came as an important factor. Age is a surrogate of corneal biomechanical properties, but the main concern I have here is that he confuses form fruits keratoconus as the very abnormal corneal topography pattern. Interestingly, a very nice study with a 300,000 LASIK procedures done by Schallhorn's group, he found cases with a normal pre-op tomography here that had ectasia, 30% of the cases, and 1% of the cases with normal, good, stable outcomes after LASIK, even 4 years and plus, would have abnormal shapes. So we need to improve the sensitivity and specificity. So what is form fruits keratoconus? Form fruits keratoconus is hard to define, includes the nomenclature. Fruits means confused, means incomplete, and this nice systematic review by Maria Enriquez from Peru, she looked at the published data on form fruits keratoconus and subclinical keratoconus. There is no uniformity on the definitions. So Rabinovitz would say that a patient with an abnormal topography with normal distance correct vision and normal slit lamp will be a form fruits keratoconus. A very nice review on the editorial on the British Journal in 2009 by Steve Kleiss would say that the fellow eye of those cases, sometimes called unilateral, and I prefer to call these cases very asymmetric ectasia cases, would be the form fruits cases. So there is no consensus. There is no consensus, and my humble contribution is that form fruits keratoconus are the cases with high susceptibility. And we first talked about that in this nice Academy paper that we presented in 2008. Interestingly, we published a couple years later, this patient that had LASIK in the left eye had ectasia, and the right eye was stable and was abnormal on tomography and biomechanical measurements. So we evolve on the biomechanics so that we have a dynamic shine flux system that can be combined with the Pentacam. And we use artificial intelligence, the random forest with Livernow cross-validation lead to the TBI. And here is the display on the JRS 2017, in which we found a very nice separation between the one eye randomly selected from normals and keratoconus, and also the ectasia eyes from these 95 cases with normal topography based on a strict criteria. We have to change the threshold, so the cutoff of 0.29 would give you less than 5% false positives and about 9.6% of false negatives. I would say that this is a very nice tool for us to improve, and this is a surrogate of corneal biomechanical susceptibility. So we have cases like this one with 2015 distance correct vision that has abnormal TBI, and this patient has a fellow eye with a mild keratoconus. So there's a very high susceptibility. So the fellow eye with a normal topography, his placido and his shine flux curvature axial maps, we have abnormality. But we can get unilateral ectasia. This patient had a ring. He did very well, and he was moving to London, and then Reinstein could confirm the normality on the left eye, and this patient was seen on 2014 before we had the TBI developed, but we had the data and we could retrospectively calculate. So TBI of 0, and he comes back a few years later with a very stable and still very low TBI. So the consensus is that unilateral keratoconus does not exist, but you have a secondary ectasia that can be caused by a mechanical process basically in any eye, and it can occur in only one eye of a patient. For example, if the patient just rubs one eye. Interestingly, it can occur in both eyes of the same patient that you can identify ectasia susceptibility. And that's the best case example I can show you. We have both eyes of this identical twin with normal topography. The first twin is a very asymmetric ectasia. In all the four eyes, you have abnormal TBI. Interestingly, we were able to do the gene testing with the Avellino company. The gene profile had some identification of risks for ectasia based on these genes that are markers for inflammation of the ocular surface. Going back to the patient that we published in 2010, this patient is still stable with 2015 distance correct vision, and the patient has borderline values on tomography, but when we integrate tomography and biomechanics, we have a very nice identification of ectasia susceptibility. Very interestingly, we have to go beyond, not over, and make things more simple, but not as ridiculously obvious and easy. We have cases like this one that we learned tremendously. This patient had a high correction based on the corneal thickness in the center of the cornea. We did go ahead with SMILE. I did not pay attention to the Pentacam data, which would say would be a borderline to abnormal with the R2max values, but we did SMILE. This patient did very well in the first week after surgery. They had a 6 days post-op with 20/20 uncorrect vision. And if you do SMILE with a proper technique, the patient has a recovery very nicely. So this is the technique I learned from Dan Reinstein. I use this left hand forceps with a 0.12 just to grasp the eye, identify the upper and the lower edges of the lenticle, and then I go very gently and do a very nice dissection all up to the beyond the frontiers of the lenticle, and then I go under the lenticle and I leave a little triangle so that the lenticle does not fold inside of the pocket under the cap. So you just finish the dissection, and then the lenticle can be easily removed. If you do that, the recovery of the patient is very nice. It's similar to LASIK. Patient did well 1 year, 2 years after surgery. 4 years after surgery, she comes back with decreased vision in the right eye, and with 2100 uncorrected, corrected to 2025 with a high astigmatism. And this patient was my first case that I produced, I would say, iatrogenic ectasia. If I see the 2016, 2 years post-op, when she was still 20/20 plus, 25 plus, 20/20 minus, she would see
Sorry, we've lost Professor Ambrosio there. Sure, he will be dialing back in. Sven, do you have any?
Yeah. Sorry that we have to wait a little bit, but we have, of course, the rest of the audience here. In the meantime, as we wait, if there are already some questions, I'm sure also Renato will be back soon.
Some questions, Sven, in the Q&A?
I don't have any questions right now.
Okay.
If Renato, if it takes a while, we have unfortunately to switch a little bit the program. Don't know whether Renato can hear us. Perhaps the best way would be to dial in completely new.
Do you want me to start my presentation and maybe we do the last bit of Renato in the meanwhile?
Yes, I think this is probably the best idea.
Let me change you to the presenter role. And while I do that, Dr. Vinciguerra is going to talk to us about the CBI and CBI LVC from theory to practice. You are now the presenter. And
Thank you very much. Can you see my screen well?
Yeah, I can see you.
Okay. All right. So, well, it's really a shame that we haven't seen the last bit of Renato's talk because, well, it was fitting very well with this, but I will try to fit in. So what we're going to speak about is two indices, one that is for pre-op assessment and the other one is for post-op. So what is the ideal post-op assessment of a patient that is reliable, easy and fast, is validated with high sensitivity and high specificity? We introduced the CBI that is an biomechanical index that is aimed to separate normal patient from keratoconus, and it was done back in 2016 and was awarded with the Trautmann Prize. I will make my presentation very practical, so I will give you just a few hints of how we created it, but I want to go very much in details of how it works. So the CBI was created with logistic regression. What does logistic regression means? It's an artificial intelligence, and the cutoff for abnormality is 0.5. What is very important to know is that since the CBI was created with a curve that is very steep in the center, you will have very few patients that will be borderline, like 0.3 or 0.5, which means that most of your normal patient will be between 0 and 0.2, and most of your abnormal will be between 0.7 and 1. This is the validation set that in our article that is published in JRS, that you can read it in details, we showed a sensitivity of 100 and a specificity of 98.4. But I want to show you how it works in clinical practice. So if you have an abnormal patient, a keratoconus, you have one display that is called Vinciguerra screening report, and you see the CBI that is in the bottom right. In the bottom right, you see that is color-coded. It goes from green to red. And in this abnormal patient, you see that the CBI is 1. This is just to highlight you how it works. But then, somebody could say, well, I am able to diagnose keratoconus with placebo. Why do I need biomechanics? Let's go to difficult cases. If you have a patient like this, which is a patient that is slightly thin, is 505, normal anterior elevation, normal posterior elevation, and with a maximum K of 43, almost everybody would say that is a normal cornea. But you look at the final Belin Ambrósio, which we know that the cutoff is 1.6 to turn yellow, also is 1.18. So this could be a good candidate for refractive surgery. Look at the CBI. Here the CBI is very abnormal, it's 0.99. And then if you look at the other eye, you see that it's a very clear keratoconus. So these are one of those bilateral cases in which one eye is subclinical, because we know that real unilateral keratoconus does not exist. And obviously the CBI is abnormal also in this eye. This was published as well. We published it in Journal of Refractive Surgery, in which we showed that many patients with apparently unilateral keratoconus were showing abnormalities in both eyes. But then you might think that, well, the CBI then is reducing more the candidates for refractive surgery, but this is not true. I'm going to show you this case that is absolutely normal, a very regular astigmatism. But if you look at the Belin Ambrósio, it's 2.45. You look at the left eye, same thing, regular astigmatism, thick cornea, no abnormal posterior elevation. But again, the Belin Ambrósio is abnormal. But the CBI was normal in the right eye and in the left eye. And this patient was successfully treated with refractive surgery and stable since years. So this is also helping you to increase the sensitivity, but also the specificity. And then I'm going to show you this very interesting case that was referred to me some months ago. This patient was 49 years old and was referred for unilateral keratoconus with sudden loss of vision and considered cross-linking. When you think about sudden decrease of vision in keratoconus, it doesn't fit. So I'm going to show you this topography. You see, this is not an Oculus topography, but there is a reason why I'm showing you this. So if you look at this, you see that this looks like a keratoconus, but the left eye is absolutely normal. But then there is something that doesn't fit. So what did I do? I did the CBI, and the CBI was normal in both eyes. And then I went back to the patient, and I looked at the epithelial maps, and the epithelial maps were also very thick. So then I went back to the patient and I said, is there anything you didn't tell me about the last months? And I say, yes, I think that some months ago while I was cooking, one drop of boiling oil went to my eye, but I didn't think it was important to let you know. And the cornea was crystal clear, so you couldn't see any scar. The epithelium was hyperplastic, but the biomechanics was normal. So we suggested alcohol-assisted epithelial removal, and then the patient is 20/20 again. Now I'm going to speak about the CBI-LVC. The CBI-LVC is a new index. It just sounds like the CBI, but it's completely different and is made to diagnose ectasia after surgery. Why it is important? Because we know that even if laser vision correction is very accepted, there are iatrogenic ectasia. After PRK, LASIK, and SMILE, we have seen what Renato showed us. And the earlier we diagnose it, the earlier we can do cross-linking. But unfortunately, up to date, the only way to diagnose it was to do topographies. If you were not sure that it was a clear ectasia, you had to ask the patient to come back, and if it was getting worse, then you were suggesting cross-linking. The incidence of ectasia is low, but it's still reported between 0.04 and 0.2%. And they can happen between weeks and years. And it is important that every surgery can induce ectasia, SMILE, PRK, and LASIK. LASIK extra also does not prevent ectasia. So how can biomechanics help? Well, we know that probably the first hit is a change in corneal biomechanics. So if we are using corneal biomechanics, we might be able to diagnose it earlier. But there are a few challenges because we need to be able to separate normal patient from keratoconus, which we did with the CBI, but then we need to separate between abnormal patient keratoconus and patient after laser vision correction because they behave similarly because they are thin. So what did we do? We got a very big database and we asked for some help. People around the world from India, United States, Germany, from Switzerland, from Japan, and we put all patients together. We just published this in Journal of Cataract Refractive Surgery. Is out. There is the online ahead of print just now, and it will be in the next issues of JCRS. So we use this big data set, and we wanted also to create a semi-automatic approach, which I will explain you in a second. But the first thing was to create this CBI-LVC, which is the aim is to separate a patient that had refractive surgery, which is stable, from a patient that had refractive surgery but has ectasia, without the need to do more than one exam. So we included many patients, and some were stable after PRK, LASIK, and SMILE, and ectasia after laser vision correction. You know that ectasia is very rare, so it was very difficult to get this patient because they were all untreated, so never had cross-linking or rings. So you imagine how valuable it is to find this patient. And we were able to include 51. Just to give you an example, the article that published the highest amount of post-laser vision correction ectasia after us was 6. So it's almost 10 times more. These patients were very stable, so at least 2 years of documented stability, and all the ectasia were confirmed by 2 cornea mask experts. We used, similar to CBI, logistic regression, and we used 80% of the database to create the index and 20% to validate. The results I'm going to show you are only the validation dataset, because the training dataset is not important. You want to know how this index works in the validation one. So we have shown that we had a sensitivity of 93% and 98.5 to diagnose ectasia after refractive surgery compared to stable. What are we saying? We are saying that with an air path, we are able to diagnose a patient that had iatrogenic ectasia without the need for topography. That doesn't mean that you have to throw your topographers away, is the opposite. But what we are saying is the potentiality that you have with the use of biomechanics. Let's see how it works in clinical practice, though, because we want to see how it works. What about if the patient is coming to your clinic, but you don't know if they had LASIK, PRK, or SMILE, or maybe they don't speak your language? You want to be able to have a kind of semi-automatic approach. So we also implemented that. And what was the aim? Was the aim to automatically separate between normal patient, keratoconus, stable post-laser vision correction, ectasia. The last two we explained you with the CBI LVC. But then we needed the rest, because as I told you, the CBI, the BED-D, they are abnormal after refractive surgery because they were not designed to diagnose post-laser vision correction ectasia. They were designed to detect keratoconus, which is thin. So they see a cornea that is thin and they say, well, if it is not normal, it's keratoconus. So we included many more patients. We are more than 4,000. And we needed healthy keratoconus and the two population of V4. What was the aim? Basically, you have a patient. Is it abnormal? We wanted first to separate between normal patient and everything else, which is keratoconus and patient after refractive surgery. And we were using the CBI for that. Then we created a second step that was to give you a warning if the patient is not normal. There was a second step to suggest that the patient was looking like after refractive surgery. If you were confirming that, then the CBI LVC was applied. This sounds very difficult, but now we'll show you how it works in clinical practice and you will understand. Let me go directly to clinical practice and let me skip this because I think it's easier. Okay, so this is the Ambrósio, Roberts and Vinciguerra report. Unfortunately, Renato was not able to show you this, but this is basically a combination with random forest of tomography and biomechanics inside a single index that is called TBI. Here is the CBI and here is the Belin Ambrósio. As you can clearly see in the right, you see that this patient has keratoconus, the CBI is abnormal, the TBI is abnormal. All abnormal, but there is nothing different compared to what you're used. And also the Vinciguerra screening report, the CBI in the bottom right is 0.99. Okay, let's see a patient that is stable after refractive surgery. Then you get a warning. You see, well, you know, I think that this patient had laser vision correction. Can you confirm? Had PRK, LASIK, SMILE, had surgery, but I don't know which, didn't have surgery. Once you click, then you get the CBI LVC, which you see the cutoff is still 0.5 and is inside the green zone, so it's 0.07. In the Vinciguerra screening report, it works the same. But let me just tell you one thing, why I've grayed out these two. Because you remember that we told you that the Belin Ambrósio and the TBI are not applicable after refractive surgery, then we decided to gray it out. Same thing, Vinciguerra screening report, you click and then you get the CBI LVC. Last thing, this is an ectasia. Again, tells you, can you please confirm had surgery or not? And you say, yes, had LASIK, for example. And then the algorithm will tell you, warning, this patient probably has iatrogenic ectasia. You see that is 0.91. And obviously it looks the same in the Vinciguerra screening report with exactly the same CBI. It's important to tell you that you don't need the tomography to get the CBI LVC. The CBI LVC is purely made with biomechanics. Sven, I might stop, you think, because I didn't want to spoil Renato's case. I can't hear you. I can't hear you, Sven. Unmute you. Shall I stop?
Yes, I completely agree. I just wrote Renato. I think it's good that you both presented first the theory more, and now we start again with the case, with the pre-op evaluation by Renato, and then we look at your post-op evaluation with the CBI LVC.
Shall I stop my screening share?
Yeah, then I would say Renato could try again. If there is some other technical issue, I have Renato's case as well as a PowerPoint, so I could jump in there. But I hope Renato now everything is fine.
I have changed the presenter role, Professor Ambrósio.
Missed your introduction, Renato.
It was a great introduction. Thank you. I don't know what happened, but I kept talking here. I really am kind of frustrated because I kept talking. But this case it's worth to come back. It's a 26-year-old female that comes with a high myopia, and despite of the Belin Ambrósio data, the Artmax was relatively low. We were in 2014, really excited about a SMILE, and I decided to do SMILE for this patient. And when we do SMILE, when the technique I learned from Dan Reinstein, the patient does very well. We identify the upper and the lower lenticles of the case, and then we remove it very nicely. SMILE is a procedure that evolves in terms of the biomechanical improvement in terms of LASIK, not an improvement, but lower impact. And this is something that I learned back in the back in 2012. This concept was introduced by people like BJ Dupes and Abhijit Roy that is with us. So if you do the proper technique and it goes back to the hands of the surgeon, you have a very nice result. And this patient did very well. In 6 days after surgery, she was 20/20. Follow up with 1 year and 2 years doing very well. But in 4 years, she comes back with decreased vision in the right eye. And unfortunately, we diagnosed ectasia and told this patient that I devote my life to avoid ectasia, and she was the first one that I had. The first thing I learned is that if I paid more attention in the 2 years, I would see a posterior elevation. You have to normalize using the same best fit sphere, but this is something that you could have been detected and have a closer follow-up. And eventually just saying to the patient not to rub the eye may have been a difference in her. And the left eye is not ectatic at this point because of the clinical scenario. She's doing well, but epithelial thickness helps you to identify this. Patient was advised not to rub the eye. Oral riboflavin makes a difference treating the allergy. And we did femtosecond ring implantation with injection of riboflavin inside of the pocket. And this is something that we do as in some of the keratoconus patients and ectasia patients that we treat, and we use a fast cross-link with 9 milliwatts per 10 minutes. This is the 1 year post-op. The patient did well, 20/40, corrected 20/20 in the right eye. You see the change that she had in the first month to a year, and you can see that and correlate that with epithelial smoothing on the surface. And interestingly, this patient had some improvement in SPA1 that makes the cornea stiffer, but we are still learning how to interpret this type of data. And interestingly, you see the change here in the OCT with a central demonstration of cross-linking. The fellow eye, I saw that recently is with Riccardo, great work on the post-LVC, is looking now normal and still stable if you change it to the post-LVC with a SMILE. So it's a very important thing. But what we learn is to avoid ectasia, not to treat ectasia. This patient would have been detected as susceptible based on the TBI. The TBI was not ready in 2014, but since we have the data, we can back calculate, and 0.72 will be a very important sign for ectasia susceptibility. So what did I learn is that we have to keep ourselves evolving. And this is a message that we sometimes know something and we think we are right, but we have to know much more to really know that we are not right and we are wrong, that we have to evolve. And that comes with the need for the evolution. We have many cases that were presented in meetings and published that we compiled in this nice review by my colleague Luisa Spocarte. And we have the need for artificial intelligence evolution. And we have a larger population with a better training. And you see 500, 5.1 normal topography eyes and patient that had ectasia in the fellow eye. And we improved the algorithm, and the brain group was very instrumental with Elias Leão for helping us to create the random forest second generation, in which we have an improvement from 75.7% to 84.4 with a higher cutoff value. So we are still learning how to interpret the higher number in some of the normal cases, but this is important. And if you see the refractive toolbox, we have surface ablation, LASIK, SMILE, and phakic IOLs. And based on the TBI, based on the patient clinical data, this will be very instrumental for me for making my clinical decision. What will be the best, considering the impact from surgery, considering the level of correction, and of course, ICL and ICRIL phakic will be good options for many of these patients, or eventually if the patient is a therapeutic case with keratoconus. So I'm sorry again for the technical problems, and thank you very much for your kind attention. I look forward to the discussion. Thank you, Riccardo, for the great talk and great introduction.
Thank you, Professor Ambrósio. So shall we jump back to Dr. Vinciguerra's talk? I will make you the presenter again, and we will address some questions a little bit later.
Okay. Well, it's just a few slides, actually are 2 slides. I just wanted to show one nice thing is that the case of before, so you remember the one that Renato just showed you, so the ectatic eye, what we have seen was very interesting is that does the CBI, because many people think, unfortunately, and this is very unfortunate to me, that only LASIK can cause ectasia. So we have seen that PRK is able to cause ectasia, SMILE as well, LASIK as well. So does the CBI-LVC is able to detect ectasia? And the answer is yes, because ectasia is the same thing, regardless of which surgery caused it. So we are able to see that the right eye, the ectatic eye that was successfully then treated, sorry, I don't know why it went back, by Renato, it was seen as ectatic by the CBI-LVC. So it's a good way to diagnose ectasia regardless of the surgery that caused it. And I'm done. That was my last slide.
Thank you very
Thank
much.
you very much.
Yeah, Renato and Riccardo. I think we have perhaps just time. I don't see any question coming in, but perhaps, yeah, I think very impressive case that you can really see how the Corvis can help pre-operatively to perhaps avoid this situation, and then post-operatively to detect actually if there is any problem. Could you give Riccardo perhaps a little bit an outlook about the CBI-LVC? I mean, about clinical situations where, or what follow-up studies, what you would do for clinical situations in terms of follow-up, or
So, well, thank you for the question. So regarding clinical situation in which I think that the CBI-LVC is very useful is, well, obviously in any follow-up of patient after refractive surgery, because you want to know if there is anything that might look suspicious. But there is also another reason why it might be very interesting to use it. Imagine that you have a patient that has regression after refractive surgery, or you have a change in the refraction. So one of the definition of ectasia is a change in the refraction. One, not a definition, one of the points. So if you go and look in PubMed for hints for ectasia, is change of refraction. So, but that can also be caused by regression. So it could be very useful, for example, if you have a patient that is changing the refraction, but the CBI-LVC is absolutely normal, that can be a hint to tell you, maybe I'm less worried. Somebody's saying that voice is hardly audible. Can you hear me?
I can hear you very well. Thank you that someone from the attendees wrote that. If someone else, please write that in the chat if you have any further technical issues. But at least I can hear you perfectly.
Okay.
I hope this is the case. Actually, I mean, I think we have plenty to discuss after the whole talks. I think now it would be time to jump to the next talk. And yeah, as I'm just speaking, I might just do the introduction. Abhijit Roy will speak now about a very nice different approach with the Corvis based on simulations of the actual refractive surgery, and he will show you how he can nicely predict stiffness after refractive surgery with his very, very impressive software.
Thank you, Sven. I'll just share my screen. Okay, so I hope you're able to view this. All right, so Sven just gave a very brief introduction. So indeed, this is the newest software that we have come up with, you know, using the measurements that the Corvis gives and the Pentacam. And this is a project which has been running for some time, and we are very happy to see that now this has resulted in a software which can be used in clinics and can be run by the clinicians with a few keystrokes. So this is our primary development team on the clinical side with Dr. Rohit Shetty and Narayana Netralia. And over the last few months, you know, I would also like to thank Dr. Prema and Riccardo for, you know, diligently helping us in validating and testing our software. Over the years, many clinical fellows have also helped us. So unfortunately, I can't name them. So if you look at evolution of refractive surgery practice, okay, so we started with Placido, then we came up with several scoring grid systems, risk scoring systems. Then we had Scheimpflug imaging systems, and then sometime in the late 2000s, you know, we had actually biomechanical tools coming up, the Corvis being the latest addition to this. So when we talk about in vivo corneal biomechanics using the Corvis ST, both Riccardo and Renato have spoken a lot about these different indices that are currently available for helping us, you know, predict whether a certain cornea would end up being ectatic. So one of the deficiencies which we felt was that we are using these preoperative information, but we had actually no true prediction of what the postoperative biomechanics of these corneas would be. So currently this is not possible at the clinic, and therefore this is where we felt that we needed a true simulation-based software where we could integrate tomography and biomechanics, and it would give you an estimate of where the cornea would end up for a given type of surgery, whether it's PRK, LASIK, or SMILE. So why this is important. So this is an example of a case, 26-year-old female came for refractive surgery opinion. One eye was 6 diopters. The other eye was also close to the same refractive error. If you look at the BAD-D, CBI, and TBI, they were really not that worrisome for this case. Refractive surgery that was planned for this patient was SMILE. And when the patient came back 3 years later, there was ectasia. So, you know, every now and then we will come up with some of these ultra difficult cases, I would say, where, you know, the indices which are based on evaluation of the preoperative Corvis measurements using, without using, you know, simulation-based biomechanical tools may fall deficient. And that is where we hope to bridge the gap so that in addition to the currently available indices, by combining with advanced simulation, which is based on actual scientific hypothesis of biomechanics, you know, we can give you a better estimate of what the postoperative biomechanics would be. So this is where the basic question is, can we predict these changes? So we published this a few years back where we introduced how we can use something known as finite element modeling for determining what would be the post-operative corneal stiffness when measured with the Corvis ST. And we included surgery-specific collagen remodeling features, something known as also Bowman's layer crimping, into these sophisticated models. And this paper is freely available for everybody to download and read. To briefly summarize what was there in this paper, so on the left side, you have one figure where what we compared was a preoperative measured versus estimated. This was from this. This was basically what was measured preoperatively. The dotted line shows the estimated from our simulation models. And when we compared what was predicted by the software, which is in this case AcuSimX now, with the actual post-operative measurement, you can see how nicely it compares. So here, actually, you would be able to generate what the post-operative Corvis ST deformation amplitude with the amplitude would be with the help of this software. So that's a big plus. So even before you have made a single cut, you can run the software and generate what would be the post-operative deformation amplitude for a given surgery. And you also have the option of testing out different surgical platforms. So you can test SMILE, you can test LASIK, you can test PRK. So this is what the software is currently. We call it AcuSimX. So we start with something known as a three-dimensional model of the cornea, which is a corneal mesh, which we can derive from Pentacam. We have the deformation measurements. We first run something known as an inverse FEM. So this is basically a step where we determine what the biomechanical properties of the cornea would be in terms of sophisticated biomechanical models. I'm not going to the depth into those because those are not relevant to this talk. Once we have, and you can see how the deformations are happening in terms of a simulation mode. Once we have derived the biomechanical properties, we choose the relevant surgical parameters for the patient, simulate those parameters on the same corneal mesh, perform the surgery-specific FEM modeling. There is some amount of artificial intelligence also involved, and we finally end up with what would be the estimated post-operative corneal stiffness of the cornea. So this is basically the overall purview of the software. So what are the features of the software? Well, first of all, this is the world's first sophisticated finite element simulation and AI-powered prediction tool. So in the past, we have always been using this in research labs, but now this is available for use in the clinic. For the clinicians, it will be very easy to use. It's very user-friendly. You can predict the post-operative deformation amplitude even before the first cut is made. We have different surgery-specific modules, which are SMILE, LASIK, and PRK. And something which is a little bit futuristic at this point is like we can include a uniform epithelial thickness, which is obviously you can view this currently in the clinic, but in the future there is scope for even a variable that is a spatially varying uniform epithelium thickness also that can be included in the simulation modes, but we have that right now in the software. This is the other window of the software where you can view the patient database. So we have been very lucky to partner not only with our clinical center here in Bangalore, India, that is Narayana Nethralaya, but also with Dr. Prema in Shankar Nethralaya and Dr. Riccardo in Italy. And in combination with these multiple centers, we went ahead and looked at over 529 eyes. We looked at what was the prediction errors, and we successfully predicted the post-op biomechanics of 7 ectasia eyes, and these 7 ectasia eyes are were available to us because for these eyes, we had both the pre and post-operative measurement to compare. And for each eye, you can do this predictive simulation in just 20 keystrokes. So the figure on the left shows a comparison of what the software predicted, which is on the horizontal axis, and what was measured in vivo. And you can see that most of the eyes fit very well within the 95% prediction interval. The dots which you see in red are actually the eyes that ended up being ectatic. And you can see that most of these eyes do fit within the normal population. So this is where simulation adds that additional power, where you can preoperatively determine where which eyes may end up being ectatic, even though preoperative tomography and biomechanics look to be pretty okay. And based on our outcomes from the AcuSimX software, we have actually come up with a very simple nomogram where using the software-derived parameters, we can actually give you an indication of which eye may end up being, which cornea may end up being ectatic. And like both Riccardo and Renato mentioned, that with ectasia, getting the number of cases is always a big challenge. And we look forward to adding more and more cases to our database for refined assessment of ectasia. So this is a very short video of how the software works. So this is where it opens up. First, you select which is the type of simulation. For example, here is SMILE. Then you import the Pentacam tomography files. You also import the Corvis tomography files. You enter what would be the simulation parameters, the refractive errors at vertex distance of 12 millimeters, uniform epithelial thickness, and add to run queue. So this is it. You don't have to worry anything else about creating these simulation models. Once the simulation is done, you can go to the patient viewing database, and there you can generate the reports, which will give you what would be the preoperative stiffness, what would be the postoperative corneal stiffness for the given type of surgery, and for the selected surgical parameters. So system requirements for AcuSimX, well, you don't need a supercomputer to run them. The most standard computers available in clinics can easily run this software. Riccardo is there among the panelists, so maybe he can add some comments on if they had any issues running them in their standard computers. But right now we only have the software for Windows 10, 64-bit. In future, we'll also have a Mac version. Again, it's very easy to use, and you don't need really sophisticated computing platforms to run them. What's next for the AcuSimX platform? Well, we are very happy to just give you a brief preview here, where we are also moving towards a simulation-based platform for corneal cross-linking using the Pentacam data. So you have the Pentacam tomography map on the left side, and what you see on the right is basically a normalized degeneration map, where the red indicates the problem areas in terms of biomechanics for this particular cornea. And why we see something like this happening in the near future is when we treated this cornea, and this paper is currently under review, this was the outcome that we got when we performed a customized corneal cross-linking, which is a spatially varying UV profile. The outcome is there, as you can see, that it's quite profound remodeling. But what's very important is that we achieve this remodeling with a UVA energy density of 4.63, which is even lower than the Dresden protocol. So there have been some studies in the recent past where people have talked about how we can go down below 5.4. And here we actually we are actually going to give the proof that if you rely on biomechanical simulations, you can actually achieve with UVA energy densities which are below the Dresden protocol, which is about 5.4 joules per centimeter square. So this is my team, and on the right side you have the clinical team. Thank you again to Oculus for this opportunity, and I'm happy to take any questions.
Thank you very much, Abhijit. I think very, very nice presentation. And I think, yeah, it really illustrates that one has if you have the Pentacam and the Corvis, you have now two options. You can use more the AI approaches, the artificial intelligence approaches that Renato and Riccardo showed, and I think which are really, really useful for the daily screening. And then you can have really more these simulation based tools. In addition, I have one question from the audience, which I think fits perfectly now to this talk, but is, I think, probably to the whole panel. Do you think it is better to do a LASIK with a crater optic zone, like treating with 6.5 millimeter instead of 6 to prevent ectasia? That was one question from the audience.
I may take this one. And after that, I have a question to Abhijit. I think we should think about pupil size and optical quality of vision, and I would not sacrifice too much of the effective optical zone for saving biomechanical properties. If the patient has good characteristics for ectasia prevention, I would say LASIK is okay. Go for 6.5. Do not. Eventually, you have some calculations you can do with the PTA and residual stromal bed, but eventually that's not exactly the main problem. It's different than when you do an enhancement. If you do an enhancement, probably you weaken a little more. But I would say sticking with the 6.5 as a minimal, that would be my suggestion. If the patient can do surgery, I would do 6.5. I would not consider too much to reduce. And I have seen people going down to 5.8, 5.9 for saving tissue. It makes sense theoretically, but I would say it's not my optimal. But it's a preference, and of course you have to see patient by patient characteristics. I actually have a question to Abhijit, if I may.
Yes.
Great work, brilliant work. Congratulations, you and your group with Roy Shetty is excellent. How you customize cross-linking? You just customize the energy dose, or you are doing any type of light selective treatment?
So so right now the software tool will give you where the biomechanical degenerate zones probably are. Okay. So once we had an estimate of the zone, currently the software doesn't have the UVA planning tool in it. So the UVA planning tool is something which we implemented offline. So we were always conscious of the fact that, you know, that both Eberhard-Spiel and some of the recent studies talk about how we can lower the UV energy and still achieve probably the same amount of corneal remodeling if we just target the degenerate zones. And that's where even beryllium microscopy has gained so much attention. But here we are going towards a simulation route, which is obviously going to be a simpler option if we give that as a software. Okay, so in future we will have a software included within the AcuSimX where we can customize the UVA profiles also. So right now we have done that offline, and we ended up using much lower than what the resident protocol is right now.
But you just changed the dose, or you're doing the mosaic treatment with the light, with the selection?
So the mosaic treatment currently, which is the machine from Abhijit Roy, well, now it's Flockerzi. So when it comes to the customized treatment, you have to keep the intensity fixed. Okay, you can't change that too much, but you can titrate the time, and you can titrate between a continuous and pulsed. So this treatment is a continuous treatment that we used, and the maximum treatment time for a given eye was around 12 to 13 minutes. I mean the UVA on time. Okay, and it was a continuous treatment. Yeah.
Excellent. Thank you.
Yeah.
Excellent.
Yeah.
So I think we move on then to the next session. The next session will switch a little bit from refractive surgery to keratoconus and keratoconus management. Due to the time delay, Michael Belin is not present here live, but he has recorded his talk.
What I will be discussing today is determining keratoconus progression using the Belin ABCD progression display, both pre and post cross-linking. So the first question I often get is, why a new progression display? After all, we have the Belin Ambrósio or the bad display. Can't we just follow the final D? We also have the ABCD staging. Can't we just follow the parameters from the staging or grading system? Well, the bad display is designed specifically to separate normal from abnormal. The final D shows variance from normal, but not necessarily keratoconus. And here are some examples. The picture on the lower left is post-refractive, obviously an abnormal, quote, not normal cornea, an abnormal final D, but not keratoconic. The upper right is hyperopic LASIK, which looks, at least on the anterior surface, very much like keratoconus, but again, an abnormal final D, but not keratoconus. And the lower right one is what we see with endothelial dysfunction. Again, an abnormal cornea. You can see the corneal thickening by the flattening of the PTI graph, the lower right part of the display. Again, all these have abnormal final Ds, but they are not keratoconus. Again, I'll get asked, well, why don't we just follow the parameters from the ABCD staging or grading system? Well, the ABCD grading system was really designed for population-based studies, not really to follow a single individual patient. And what do I mean by that? Let's look at the picture on the lower right. This is body mass index. If you look at the green, normal BMI is anything from 18.5 to 24.9. Well, a person can start off at 18.5 and go all the way up to 24.8 and still be in that green stage, but they've increased dramatically. Another individual can start off at 24.8 and go to 25, a small change, but will jump an entire stage. So stages are good for population-based studies, but not really good to following an individual patient. The need for a new progression analysis was known in 2015 when we produced the Global Consensus on Keratoconus and Ectatic Disease, the work of the 4 major multinational corneal societies. And what did they conclude? They concluded that there was no consistent or clear definition of ectasia progression, that ectasia progression is defined by a consistent change in at least 2 of the following parameters, and this is the important part, where the magnitude of the change is above the normal noise of the testing system. And those parameters were steepening of the anterior corneal surface, steepening of the posterior corneal surface, and thinning and or increase in the rate of corneal thickness change, or pachymetric progression, from the periphery to the thinnest point. If we look at all the prior progression parameters, and this is a long list of parameters that have been used in published studies, if we look at this entire list, other than pachymetry, every one of them is based on the anterior corneal surface. And what does that mean? That means that we have to have a change on the anterior surface leading to a decrease in visual acuity, or at least an increase in visual aberration, before we can diagnose progression. And that's not really how we want to diagnose disease progression. The goal of any part of medicine is to identify disease at the earliest possible stage and intervene or cure the process before sequelae develop, particularly permanent sequelae. And that's not what we currently do with keratoconus and with cross-linking. We're mandated by insurance companies now to wait until we get a 1 diopter change in Kmax in most countries and for most insurance carriers, which almost always means that the patient has had a permanent decrease in visual acuity. Well, we need a whole new approach. The reliance in the past, and most people agree now that Kmax is a terrible parameter, but the reliance on Kmax as both an efficacy parameter and an indicator of progression has resulted in irreversible loss of vision and delayed intervention, when the goal should be intervening at the earliest possible stage where we have documented progression. So the ABCD progression display was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals, one-sided because we're only interested if the cornea steepens and or thins, so again, one side change. It allows to documenting progression in spite of a stable anterior surface or a stable Kmax, and it evaluates each anatomical layer individually. In order to do that, we looked at the ABCD parameters, and again, D is not an objective measurement, but user entered, so really just the ABC. And based on that consensus document, we needed to determine the noise of the measurements. And the A parameter, which is the anterior radius of curvature, taken from a 3 millimeter zone centered on the thinnest point, and the B, which is the back or posterior radius of curvature, were new parameters. So we needed to determine the noise inherent in those measurements. We also decided it was important to study 2 different databases, so 2 different populations. For you older patients with clinically evident keratoconus, we used a keratoconic database, which seems logical. The older patient also is less likely to exhibit rapid change, and the risk of waiting is low. But for your young patient or your patient with very early subclinical disease, the noise measurements in that group of patients probably more closely matches a normal population. Additionally, the younger patient with normal vision and subclinical disease, the risk of waiting is higher because we know that subgroup of patients can change very rapidly. And here you can see the both standard deviations and the 80 and 95% one-sided confidence intervals. And as you can see and what you would expect, the noise measurements in red or the keratoconic populations are greater than those in green. And again, we used both an 80 and 95% one-sided confidence interval. And this is what the current iteration of the display looks like. It's actually the second version. It allows you to look and display up to 8 exams over time. It will display both the 80 and 95% confidence interval in red for the keratoconic population and in green for the normal population. It allows you to indicate when and if you've done a cross-linking procedure. That's shown here in the black dotted line on the horizontal. And if you notice, once you've indicated a cross-linking has been performed, the confidence intervals drop out because they weren't performed or they weren't computed on a post-cross-linking patient database. That's something we'll be discussing later. We show the information graphically, we can see in the upper part of this picture, but we also show a number of different parameters in tabular format below. And you can see again, we have the date and time of the exam, the ABCD staging, the BAD-D, the progression index, ART max, Kmax, Q values, and a number of anterior surface parameters. So again, if you choose to follow those, we show them in tabular format. As I already alluded to, once you show that there's been a cross-linking, the confidence intervals are removed, as you can see here. Here's a clinical example showing the utility. This is a 15-year-old, very early keratoconus, 13-month follow-up. If you look at the Kmax, we actually show it on the right, but also circled in blue on below. You see there's effectively no change in Kmax. So for most countries, this patient would not be at least paid for by insurance companies. But if you look at the B parameter, the posterior surface, by the second exam, we're well past the 80% confidence interval, and by the third exam, well past the 95%. Documented progression in a 15-year-old, in spite of the fact that you have a stable K max. Here is another example of a 16-year-old. You can see here the Kmax goes from 48.9 to 49.8, just under that 1 diopter limit. But look what's going on. The anterior surface well past the 95% in the green parameter, which is what you would use in a 16-year-old, well past the B parameter, well past the C parameter. Markedly progressive disease. But we would have to wait to another exam on this patient before we get insurance coverage. That's not the best way to treat a patient. An 18-year-old with stable Kmax, again, you can see on the right eye shown on the left example here, some changes on the posterior surface, but the right eye, again, marked changes on the posterior surface, well past the 95% confidence interval. And it's not just early disease, here's progressive advanced keratoconus with a stable Kmax, but again, you can see the posterior corneal surface and the corneal thickness well past the 80% for the posterior surface and well past the 95% for corneal thickness. Again, advanced disease that would not show progressive change based solely on Kmax. But how do you define progression after cross-linking? As I've already said, currently the confidence intervals are dropped out if you show cross-linking. So we did a study with the Elser Institute in Switzerland and the Hamburg Keratoconus Center in Germany. We looked at patients with a minimal of 12 months post cross-linking. We used 2 sites because we felt this was a surgical procedure which inherent user site variability. You can see we looked at 60 patients, 38 from Zurich, 22 from Hamburg. The average age was 29 in both centers. But if we look at the range of post-op, in Zurich, it was between 12 and 28 months, but in Hamburg, it went all the way out from 16 to almost 10 years. And you can see on the right the noise measurements. They actually end up falling between the preoperative normal and the preoperative keratoconic. We looked at geographic comparison, and it turns out both Zurich and Hamburg had similar ABC values, and if you look at the graphs below, they also had similar noise measurements. We took the Hamburg patients, because there was such a wide length of time postoperatively, and we compared short duration, 1 to 3 years post-op, to 3 to 10 years post-op, and again, there was no significant difference between these two groups, indicating that once you get past 12 months, the noise levels seem to be stable. And this is the new, soon to be released display version 3. You can see here that the post cross-linking confidence intervals are shown in blue, and they will only appear at the 12 months or later post-operative exam. So here you can see we have 2 exams post cross-linking, but neither of them have reached the 1-year post-op period, so the confidence intervals will not appear until you have at least 12 months post-operative. The display can actually get fairly busy, but there's ways to work around that. Here you can see we're just selecting the appropriate gate. In this case, for a 16-year-old, we selected green gates, so we're not showing the red, which makes it a little bit easier to read. Additionally, if you're only concerned about post-cross-linking progression, you can select and remove the preoperative exams. You use a drop-down menu circled in red here called Select Exam. And here I've removed most of the pre-op, leaving only the one immediately before the cross-linking procedure. And here you can see again, the display becomes much easier to see. Again, I'm only showing the one exam right before cross-linking and then the post-operative exams. And again, you'll notice that the confidence intervals only appear 1 year or later. Here's an example of a good response to cross-linking. And here's one that you would need to follow as possible retreatment. You can see on the A parameter, it looks like that last exam is really just past the 95%, and the B surface, we're past the 80%. Now, I would normally recommend that you do at least 2 exams to make sure this is correct, but this is a patient that would need more careful follow-up. And again, you can eliminate the preoperative exams. Here, I just select the postoperative exams on that same patient. Makes it just a little bit easier to read. So in conclusion, post-cross-linking measurement variance or noise can be used to determine progressive change. The noise measurements appear consistent across different centers as long as we're doing the standard Dresden protocol. Noise measurements are consistent at 12 months or longer, and the post-cross-linking confidence intervals will be added to the next iteration of the Belin ABCD progression display. I'd like to acknowledge my co-investigators, and thank you very much. Take care.
This is a great talk from Michael, and one of the main aspects that we have in the clinical practice is to determine when to do cross-linking in a patient. Recently in the JCRS, there was a very nice case report, which I was happy to contribute with my opinion, and I stated briefly that cross-linking is a Nobel Award deserving work, but it should not be considered as something for prophylactic keratoconus for every kid. And I see Riccardo has one of the longest experience with Paolo in Italy of cross-linking, and we all agree that's a great procedure, but if you do it when you don't need it, you probably cause much more harm and problems to the patient than benefit. So this is a very important tool to detect when the disease is progressing. Eventually, when we see the patient for the first time, the biomechanical assessment, the work that we just seen by Riccardo and Abhijit Roy would give us prognosis so that we can predict the patients that are likely to have more progression in terms of ectasia, and eventually we can do a closer follow-up or eventually even treat sooner. So safer and more efficient is the way to go, and having more data with the multimodal imaging is fundamental for that. So I leave to Sven again for the next questions.
Yeah.
Eventually.
Yeah, I would also invite the attendees again to ask questions through the Q&A. You mentioned, of course, just the biomechanical assessment and that it might give a prognosis. Riccardo, could you just explain why the CBI and Renato also the TBI were really not developed for staging or giving a progression analysis?
Yeah, I think this is also a very good hint for the next talk, because the CBI and the TBI were created in a very different way, but with the same principle. So the same principle is everything that is diagnostic needs to have a very clear cutoff between normal and pathological, and it should not have a lot of patient borderline. So that is the reason why when you have an abnormal patient, it will always stay abnormal. So if you have a CBI of 1, even if you do cross-linking or anything, it will always stay 1. And that's the same thing for TBI. So I think this is also a good hint for the next talk that is going to be given, right?
Exactly, yeah, because of course, as you mentioned it, this is a missing piece in the Corvis. I mean, I of course it's an important additional information, biomechanical staging and progression, some kind missing piece of information, and this missing piece of information, Elias Flockerzi and his Professor Seitz from Hamburg University. Investigated with the Corvis. Elias Flockerzi is here, but he just sent me a message that he had to go to the operations theater, unfortunately. So we have a recording of his talk as well, and so we will again listen to what he is saying by his recorded talk.
Dear ladies and gentlemen, dear colleagues, I would like to begin by thanking Oculus for organizing this webinar and for the invitation to give a talk on biomechanical keratoconus staging. The idea of a biomechanical staging is not that new, but our aim consists in adding a biomechanical staging parameter called E to the ABCD keratoconus classification. It is a great honor for me to speak here today, together with the other internationally renowned speakers. Since I think that the majority of the audience has never heard of Hamburg, I would like to show you briefly where I am speaking from. Hamburg is a small town in Germany, near to the French border, and in 2010 we established the Hamburg Keratoconus Center with the aim of conducting research on keratoconus, and up to now our database consists of more than 2,000 patients who presented in our ophthalmological department, as shown in the figure to the right. This first study analyzed the ABCD stage distribution at different ages based on 1,917 corneas of 1,000 patients within the Hamburg Keratoconus Center. This left figure here shows that we found a male preponderance in all decades of age. The highest keratoconus prevalence occurred in the age range from 21 to 30 years. The figure in the middle shows a comparison of the anterior radius of curvature in green and the posterior radius of curvature in red. There were significantly more corneas classified A0 than B0 in all age groups, and the same applied for A1 and B1 and for A2 and B2. There was no significant difference between the absolute number of corneas classified A3 and B3. Significantly more corneas were classified B4 than A4. The figure on the right side shows the 5 most frequent AB combinations in this study that accounted for more than 70% of the corneas included in this study. We concluded that the stage distributions in all age decades were similar, and that early keratoconus rather becomes manifest in the posterior than anterior corneal curvature. Advanced stages of posterior corneal curvature do coincide with early and advanced stages of anterior corneal curvature. Now we turn to corneal biomechanics. 15 healthy controls and 112 keratoconus corneas were examined 5 times successively with a Corvis. The dynamic corneal response parameters A1 velocity, deformation amplitude ratio 2 mm, integrated radius, stiffness parameter A1, and the Ambrósio relational thickness through the horizontal profile were investigated for each TKC stage. The Corvis biomechanical index is reported to consist of these parameters. We see that these parameters differ stage dependently between the TKC stages. The velocity of inward applanation A1 increases with increasing keratoconus severity. And the same applies for the ratio between the central deformation and the average 2 mm on either side of the center, and also for the integrated radius. The stiffness parameter A1 and Ambrósio relational thickness through the horizontal profile decrease with increasing keratoconus severity. The CBI showed a wide range of values in stages TKC1 and TKC1 to 2, and that's why we also looked at the TBI, which combines biomechanical and tomographic data. The TBI was close to 1 in all TKC stages, which indicates a good separation between healthy and keratoconus corneas. The reliability for all parameters was excellent, independent of TKC stage, with a Cronbus alpha larger than 0.834. As written in the title, the aim was to establish a relationship between the tomographic parameters of the ABCD classification and corneal biomechanics. This study was based upon 448 keratoconus corneas from the Homburg Keratoconus Center and 112 healthy controls. The CBI was transformed into its linear form, the CBI beta, because the nonlinear CBI itself does not provide information about keratoconus severity. All 3 tomographic parameters were highly correlated with the CBI beta, with comparable results for anterior and posterior radius of curvature and a moderate correlation for thinnest corneal thickness. Then the CBI beta was adjusted linearly to the scale of posterior radius of curvature because it has been reported first to be a suitable screening parameter for the early detection of ectatic corneal diseases, second to distinguish between keratoconus, subclinical keratoconus and healthy corneas, and third to be a sensitive detector of early corneal ectasia. We propose to call the adjusted CBI beta the Corvis biomechanical factor, CBIF. The coefficients of determination indicate that the CBIF regression models 76% of the variance in anterior radius of curvature, 79% of the variance in posterior radius of curvature, and 72% of the variance in thinnest corneal thickness. To obtain E stages in analogy to the ABCD classification, the CBIF range was divided into 5 stages E0 to E4. Stage E0 was characterized by values smaller than the 2.5 percentile. The thresholds were created by dividing the CBIF range between the 2.5 and 97.5 percentiles into 4 groups of equal values, E1 to E4. Next, the frequency distribution was analyzed and independently validated based on another 860 keratoconus corneas dataset from Milano and Rio de Janeiro, which revealed that E was relatively normally distributed in both datasets. The screenshot on the right side shows how E could be integrated in the Corvis display to provide a biomechanical staging for keratoconus monitoring and progression analysis. Next, the question arose whether E could also be used for early detection of ectatic corneal diseases. A0, B0, C0 does not exclude the diagnosis of keratoconus. In fact, the ABCD classification detects keratoconus in this example. We see on the left side that the exact staging for this eye is A0.0, B0.3 and C0.4. On the right side, we see a reduced thinnest corneal thickness of 534 microns, a posterior elevation larger than 13 microns, and a final Belin Ambrósio deviation of 2.99, which is indicative of keratoconus. The eye in this example was also classified A0, B0, C0 in May 2018. On the right side, we see the Corvis examination of May 2018 with a CBI value of 0.53. The follow-up dates from October 2018. The classification is again A0, B0, C0, but the CBI increases up to 0.99. Even without having calculated E for this example, this finding indicates that the Corvis might measure progression earlier than tomography. Also in the Corvis display that compares both examinations, the results indicate a slightly increased deformation in the follow-up exam of October 2018. The Corvis also states that the cornea was rather softer and more prone to deformation during this follow-up examination. In our study, there were 28 corneas in each dataset that were classified A0, B0, C0, and some of them were classified E1 or even higher. Therefore, E might detect corneal abnormalities even before tomographic changes become apparent. Thank you for your attention. On this slide, I have once again summarized the most important results. First, the Corvis measurements are of excellent reliability independent of keratoconus stage. Second, the Corvis biomechanical factor CBIF is the linear term of the CBI which is adjusted to the scale of posterior radius of curvature. Third, E1 to E4 results out of the division of the CBIF range between the 2.5 and 97.5 percentile into 4 groups, and E0 represents values smaller than the 2.5 percentile. Fourth, E1 might indicate keratoconus earlier than ABCD. This is marked with a question mark because we still have to answer this question finally. Finally, I would like to thank Dr. Sven Reisdorf for his support and help in this study. I also would like to invite you all to our Hamburg Keratoconus Symposium, which will take place on the 4th of September of this year and is planned as a hybrid event, this is to say on site with us in Hamburg, but also as a broadcast online.
Really nice presentation from Dr. Flockerzi. I think probably he's still not here because he has to be in the surgery room, but luckily we have Riccardo here who has participated in the study as well, and I think it's worth still to discuss a few aspects of the study. I mean, first of all, I think it's also important always to distinguish between detection of the disease, staging, and progression. Perhaps you can start with these
Thank you.
aspects.
That's really a good hint because it was something that actually we had to kind of discuss with the reviewers as well. So the reason why the CBIF or the E value is not created for detection is because really we use the CBI that is done for detection and we modified it to not be done for detection anymore. So it's obvious that then if your aim is to modify it to a term that is then for staging, then it's not for detection anymore. So it's also clear that you might have a patient that could be a stage 1 or 2 and is early tomographic changes, but still the E value is not created for detection, it's created for staging. And that's also because you might have a patient with an abnormal CBI and TBI, and the E factor might be very early.
Yeah, so that is, I think, a very important point, and I hope, yeah, as Mr. Flockerzi pointed out, the e-staging is directly developed based on the CBI, but giving a scale that it gives you the different stages. And a hint how the software might look like was also given in his presentation, and it's planned for the ESCRS to show the software. Yeah. Any questions from the audience?
Not as far as I can see.
I also don't see. Yeah, any other aspects regarding the study as you were involved, or anything which you think is very important clinically, Riccardo, regarding the staging?
Well, I think that, I mean, to me, this is a really exciting project. I'm one of the authors, so that is probably also why it's exciting to me. What I would like always to say as a scientist is that everything that we introduce, we will need to validate in clinical practice. So it will be a very good hint for everybody of us. But I think that we will need to see how this will work in clinical practice for decision making. So I think that everybody of us will need to use this together with everything that we have, because very frequently we have doctors that are saying, well, I have the CBI now, can I stop using the Belin Ambrósio? And this is the same. We cannot stop using the ABC because we have the E, or using the TBI rather than the CBI is something in addition to what we have, is not instead.
Yeah, I think that's a very, very important point. I think even also Professor Seitz and Elias Flockerzi, who are the main authors, would never claim that it should replace anyhow the tomographical staging. I think that is for keratoconus management always the first way.
Absolutely.
But it's a nice and additional tool. And yeah, as you pointed out, probably what the clinical decision making when the E staging shows some progression and the ABC still does not, I think that is part of future.
What it will be very interesting to see is if after cross-linking somehow the E staging goes a little bit back, because that instead could be possible. That could be possible.
Right. Yeah, so that the last talk I think was giving to all of you a little bit an outlook, what is also on the agenda and is currently the scientific steps for the next, the next features to add additional clinical useful tools for the Corvis. We have now 90 minutes of webinar in. I think, and I'm happy that still 100 participants here are still listening. So I hope everybody of you finds it still very, very interesting. And two of the panelists are still here. If there would be some final questions, I think otherwise, we will.
There's a question, Sven, one last question. Do you do topo-guided PRK and cross-linking at the same time for post-LASIK ectasia?
Well, I think that I have to reply in this case because Abhijit is not a clinician. But my question is, my answer is absolutely not. And the reason is because I always say that to me, whenever you have an ectasia, it's like the Leaning Tower of Pisa. You don't want to push the tower on one end and then push it back on the other end. So if you have something that is moving on the worse side, you just want to stop it as it is. So to me, the only thing that you have to do is either rings, if you like using rings, or cross-linking. I would not ablate the cornea anyhow.
Thank you. I think that concludes today's session. We've gone on for a little bit longer than expected. But thank you to all of you who presented. Thank you to the audience who listened, joined, and took time out of your schedule. I'd like to wish you all a good evening, good afternoon, good morning. Stay safe and goodbye.
Yes,
bye.
goodbye.
Thank you. Bye-bye.